Surveillance should be a core intervention in any malaria program, but it is particularly central to malaria elimination efforts. In this session of Unit 5, we will present case detection. By the end of this session, you should be able to specify the role of passive and active case detection in malaria elimination, describe the key considerations for constructing a suspected case definition, differentiate between proactive and reactive case detection approaches, and identify populations for which active case detection may be required to achieve elimination. In this module, we will be discussing the first step in the surveillance process, case detection. Suspected malaria cases must be detected quickly in order to respond effectively and reduce transmission. Passive case detection is the backbone of surveillance efforts in all settings. However, there are locations and circumstances in which passive case detection must be supplemented by active case detection. We'll examine what passive and active case detection mean in the next slide. Suspected malaria cases can be identified through two methods: passive and active case detection. Passive case detection or passive surveillance means that patients seek care for an illness at health facilities or community health workers on their own initiative. By definition, cases that are detected passively will be symptomatic. We say that the case is detected passively because there is no need for a health worker to go out into the community to seek out the case. However, passive is not a great descriptor because there is still a lot of activity on the part of the health system to receive, identify as a suspected case, test and register the case. Passive case detection is the backbone of malaria surveillance in all settings, including elimination. Malaria programs should seek to have good passive case detection for malaria in all parts of the country. However, as we'll learn in a moment, there may be some times or some places where passive case detection needs to be supplemented by active case detection. Active case detection or active surveillance requires healthcare workers to go out into the community outside of health facilities to seek out cases. Active case detection may find people who are asymptomatic but have yet to seek care, or they may find people with few or no symptoms who are not motivated to seek care. In elimination settings, active case detection may be needed to supplement passive case detection. Active case detection may be needed when and where there are populations experiencing barriers to health care, whether perceived or actual. For example, refugees, migrant workers, nomadic people, or people engaged in illegal or illicit activities may be actually or effectively excluded from using a country's public health care system. They may be afraid or reluctant to seek care. Active case detection may be the only way to reach these populations. Active case detection might also be needed during outbreaks, while passive case detection is being improved. Active surveillance might, in some cases, be able to reduce the time between symptom onset and care seeking, and thus reduce the chances of onward transmission. However, there is not yet any compelling evidence that active case detection reduces transmission of malaria, particularly where there is already an effective passive case detection surveillance system. Now that we understand the difference between passive and active case identification, let's review the basic steps to identify a case. The first step in case identification is the development and use of a case definition for a suspected malaria case. A case definition is a set of symptoms or characteristics of people that put them at high suspicion for malaria and therefore indicate the need to be tested. Healthcare workers must understand the case definition and how to apply it to find suspected cases. We will talk about definitions of a suspected case in the next few slides. When patients visit a health facility care, a healthcare worker will screen them to determine whether they meet the suspected case definition. Screening happens when the healthcare worker asks the patient questions about their symptoms and maybe about other characteristics. All patients who meet the suspected case definition are then tested, and all positive cases are treated. Suspected malaria patients must have a malaria test, that is, a parasitological diagnosis, to confirm them as a malaria case. Testing can take the form of microscopy or rapid diagnostic testing, as we'll learn in Unit 4. All positive cases need to receive appropriate treatment as outlined in the National Treatment Guidelines. All negative cases need additional screening and testing to determine the cause of their illness and may need to be referred. How do we know which patients should be tested for malaria? We mentioned that the first step of case identification is the development of a suspected case definition. A suspected case definition is a set of criteria that is used to decide whether or not to test someone for malaria. For example, the suspected case definition could be fever plus body aches or fever with recent travel. It could even include characteristics of people, such as adult men with fever or a history of fever. People whose symptoms or characteristics match the case definition are tested for malaria. Developing a case definition for malaria is not easy because malaria causes a range of symptoms. We should be clear from the beginning. There's no perfect case definition that will identify 100% of all malaria cases or rule out 100% of cases where malaria is not the cause of illness. But despite the lack of a perfect case definition, we need criteria to guide decisions about who should get tested for malaria. Let's think about how to best construct a useful case definition. Let's review how the sensitivity and specificity of a case definition can change the number of tests that are conducted and the likelihood that positive malaria cases will be found. In this slide, we have all people who come to a clinic because they are feeling ill. Some of these patients have malaria, but most do not. We have decided to use a very sensitive case definition. A sensitive case definition may be one based on fever, which could be determined through a subjective report of fever from the patient or body temperature measurement over 37.5 degrees Celsius. Our case definition is illustrated by this red circle, and everyone whose symptoms match the case definition will fall inside the circle. If we have a very sensitive case definition, such as fever, then we will include almost all of the malaria cases. So our case definition helps us identify almost all of the malaria cases. However, we also end up testing a lot of people with fever that is not caused by malaria. It is likely that their fever is caused by something else, and we will need to test them with appropriate diagnostics to determine their illnesses. This unnecessary testing for malaria could deplete our testing resources. If we use a less sensitive but more specific case definition, such as fever plus history of travel within the last 30 days, we will test fewer people. We will miss many of the true malaria cases, but we will test very few people who end up not having malaria. Ultimately, the suspected case definition must balance the requirement for sensitivity, that is, to detect all cases, with the need for specificity to avoid testing too many people who don't have malaria and depleting resources. The tricky part in an elimination setting is finding the right balance between a very broad case definition that will be sure to pick up all malaria cases but will result in unnecessary tests for many people who don't have malaria and a very targeted test that will miss many true cases. Which is more important? A sensitive test that is likely to pick up most, if not all cases, or a specific test that targets the people most likely to have malaria? In elimination settings, sensitivity is of primary importance. We want to find all cases that may be occurring. But as we just saw, the downside of a very sensitive case definition is that we will use a lot of resources for testing and end up with only a few cases. How can we balance the need for sensitivity with the need to use a reasonable amount of resources? One thing that national malaria programs can do to balance this issue is to vary the suspected case definition within the country and by season. Here is an example of how the case definition could change within a country and by season. The country is divided into three strata. In stratum A, there is a moderate to high levels of local transmission, and it is considered a burden reduction setting. No case investigations are conducted because there are too many cases. But obviously, we still need to detect, diagnose, and treat cases. In stratum A, which is like most malaria endemic countries, WHO recommends a suspected case definition that calls for fever or history of fever with no other obvious cause. This definition is very sensitive, but the transmission level is high enough that it is likely to find many positives. In stratum B, the area is in the final phase, approaching elimination. Cases are investigated and subsequently classified as imported or local. In stratum B, The suspected case definition could be allowed to vary by season. During the transmission season or during the period that used to be the transmission season, there should be a greater suspicion of malaria, and the case definition should be set to be most sensitive. However, outside the transmission season, the case definition can be made more specific to reduce the amount of unnecessary testing. The suspected case definition can be based on fever or history of fever, with an additional requirement that the patient has traveled to a risk area. This reduces the amount of testing required while minimizing the chances of missing a case. In Stratum C, elimination has already been achieved, and the area is working to prevent re-establishment. As a result, there are normally only imported cases. In such areas, the definition does not necessarily change with the season. Patients are tested if they present with fever or a history of fever and have traveled to a malaria endemic area. However, to avoid missing a rare local case or the beginning of a resurgence, the suspected case definition should also include anyone with fever who does not respond to treatment for other common illnesses. This latter criteria will help to ensure that a rare indigenous case is not missed, even if it might take a little longer to identify it. What may be obvious by now is that there is no one-size-fits-all suspected case definition. It is likely that the suspected case definition applied in endemic areas or active foci will need to differ from that in non-endemic areas or areas with very low or no malaria transmission. The need for sensitivity must be balanced with the need to minimize unnecessary expenditure of resources. Let's stop and reflect for a moment on the following questions. What is the suspected malaria case definition in your country? Does the suspected malaria case definition differ between seasons or regions? Do you think your suspected malaria case definition is more sensitive than specific or more specific than sensitive? Is the level of sensitivity appropriate for your setting? If not, how could you make the suspected case definition more sensitive? How well understood is the suspected malaria case definition in the health facilities or by the community health workers who are screening cases? We've just concluded a section on passive surveillance and how to identify suspected malaria cases through the use of a suspected malaria case definition. Active surveillance using active case detection method is another way to identify malaria cases. Active case detection is not meant to replace passive surveillance, but to complement or supplement it. Active case detection is used in areas not covered by passive surveillance based on the routine health system, for example, remote or conflict areas. Active case detection may also be used in populations that experience barriers to accessing malaria diagnosis and treatment. Active case detection could also be used to identify cases during outbreaks or epidemics, while passive surveillance is being improved. Active case detection is less sustainable and more expensive than passive surveillance and, therefore, is never the first choice for detecting cases. Additionally, one type of active case detection, called reactive case detection, depends on having a good passive surveillance system. Let's look at the subtypes of active case detection. Active case detection is divided into proactive case detection and reactive case detection. Both require healthcare workers to actively seek out additional infections in the community. Proactive case detection means that it is undertaken in populations or areas thought to be at risk of transmission or known to have malaria cases. It is planned in advance and directed at populations or areas where passive surveillance is limited or there are barriers to accessing malaria diagnosis and treatment. It can be used at any level of transmission depending on resources. Reactive case detection means that it occurs in reaction to a confirmed case that is identified, usually through passive surveillance. Reactive case detection is not recommended until countries are close to achieving elimination, and it is possible to conduct case investigations to determine the likely location of infection. In post-elimination settings, reactive case detection around imported or introduced cases helps to prove whether there are or are not additional indigenous cases of malaria. Overall, active case detection of either type, when deployed in areas at risk of transmission, improves the overall sensitivity of the surveillance system. There are two potential approaches to conducting proactive case detection. The first, which is also referred to as mass fever surveillance, is when everyone in the target population is screened for fever or history of fever. Those with fever or history of fever are tested for malaria, with a parasitological test. Those who test positive should be treated with an antimalarial according to national guidelines and followed up to ensure a complete cure. Those who test negative should be appropriately referred. The second approach, also referred to as mass testing and treatment, involves testing everyone in the targeted population with a parasitological test, regardless of symptoms. Again, all of the people who test positive should be treated with an antimalarial according to national guidelines, and those who test negative should be appropriately referred. The first question to be asked is about the functioning of the passive surveillance system. Passive case detection is the backbone of surveillance for malaria elimination. If passive case detection has not been optimized, then first ensure that passive surveillance is optimized and operating everywhere. This means that all health facilities have the ability to diagnose and treat malaria. Protocols for passive case detection exist and have been disseminated. Suspected case definitions are available and used to identify patients who should be tested. Diagnosis is quality assured, and treatment protocols are aligned with WHO guidance and used to deliver appropriate antimalarial medication. Proactive case detection should not be used as a substitute for suboptimal passive case detection. In areas where passive case detection has been optimized, the country should determine whether their higher risk populations or areas have been defined. If not, they should first analyze their data to identify and define higher risk populations and areas. These could be mobile and migrant populations, plantation workers, miners, persons engaged in illegal activities, residents of border areas, or marginalized populations. The country should assess whether or not there is good coverage and use of passive surveillance in these areas. One reason there could be poor use of passive surveillance is if the area has a large number of afebrile or minimally symptomatic cases. If not, and it is not possible to extend passive surveillance to these populations, the country should consider developing protocols and implementing routine proactive surveillance in these populations or areas. This may be needed if there is a large problem of afebrile or minimally symptomatic cases. However, even when passive surveillance is available in an area, it is possible that populations are not accessing care because of barriers such as stigmatization or fear of authorities, or because of long working hours. If cases in higher risk populations or areas are not being rapidly identified after a symptom onset through the passive surveillance system, the reasons for delays in case detection should be addressed. However, if there are barriers to accessing diagnosis and treatment for malaria, the country should consider implementing proactive case detection in these populations or areas in order to improve the rapid detection of cases. Proactive case detection should be initiated when higher risk populations without access to passive case detection are identified. In elimination settings, proactive case detection is important for detecting both symptomatic and asymptomatic cases in the community that are not detected by passive case detection. Proactive case detection could be useful in mining areas, for example, if there are no fixed health facilities, or for refugee camps or other populations without legal standing in the country. It could also be helpful in areas where people are engaged in illicit or illegal activities and are wary of interacting with government institutions. In general, proactive case detection should be considered when malaria cases are presenting very late in their illness or not at all. The country considers it necessary to target afebrile or asymptomatic parasite carriers, or it is not considered feasible to extend passive surveillance to an area or population at higher risk. Reactive case detection starts at the health facility or with a community health worker when a confirmed case is identified. Reactive case detection is triggered by the detection and notification of a confirmed malaria case from a health facility or a community health worker. During the case investigation, the likely location of infection of the index case is identified, at which point health facility staff, or other cadre of staff depending on the country, conduct reactive case detection in the community. During reactive case detection, people residing within a predefined radius from the likely location of infection, this may be the index case's household, are tested with a parasitological test. Sometimes they are first screened for symptoms and then tested. Those people found positive are treated according to case management guidelines. For cases with a history of travel during the likely period of infection, co-travelers should also be identified, tested with a parasitological test and treated if positive, even if they do not reside in within the predefined radius from their likely location of infection. Unlike proactive case detection, which is planned activity performed regularly at specific times, reactive case detection is triggered by the identification, notification of an index case. Given the resources required, countries or areas implement reactive case detection only when case loads are very low. Reactive case detection is carried out in the likely location of infection of the index case, which may or may not be the residence of the case, and among co-travelers if the patient has a history of travel with other people to or from an area with ongoing malaria transmission. Let's pause a bit to stop and reflect. For each of the following situations, identify the type of case detection described in these scenarios as passive, proactive, or reactive case detection. Healthcare workers going tent to tent in a refugee camp to identify anyone ill and infected with malaria. Testing of all the members of a theater troupe after they returned from a malaria endemic country and one member was diagnosed with malaria. Malaria case identified by a community health worker with a rapid diagnostic test when a patient with fever came to her house for treatment. Here are some of the key points from the module. Passive case detection is the backbone of surveillance in elimination settings. Without a strong passive case detection system, elimination is much more difficult, if not impossible. Passive case detection depends on identifying suspected cases. The suspected case definition needs to be constructed so that it is sensitive enough to pick up all malaria cases, but specific enough that you do not expend testing resources unnecessarily. There may be situations in which active case detection is needed to supplement the passive case detection. These situations could include hard-to-reach areas, populations without legal access to healthcare, or emergency situations. There are two types of active case detection. Proactive case detection is planned in advance, whereas reactive case detection is triggered by the identification of a confirmed case and takes place in and around the likely location of infection.